I recognize Dr. Miller-Meeks for 5 minutes of questioning.
Thank you, Mr. Chair. I'm proud to be a sponsor of H.R. 2474, the Strengthening Medicare for Patients and Providers Act with Dr. Bouchon, Ruiz, and Barra. This critical legislation would add an annual inflationary update to physician payments under Medicare. While operating costs for medical practice has gone up by 47%, physician payments have declined 26% from 2001 to 2023 when adjusted for inflation, making it difficult for small, rural, and low-income serving practices to provide care to patients across America. It underscores the morale that was mentioned earlier, and also the increasing scope of practice by lower educated providers also puts additional pressure. Our bill stabilizes physician payments year to year and seeks to preserve access to care, which has only worsened since the COVID-19 pandemic. Dr. Dagestani, in your opinion, do you believe that stabilizing physician payments by providing an inflationary update to docs nationwide will benefit patients?
Yes, absolutely. I mean, we're talking about physician a lot, but as a practicing physician, I'm really talking about my patients. If my door is not open, if groups at APG's door is not open, so the physician payment, yes, it's about physician, but at the end of the day is being able. And we have to keep in mind that all commercial reimbursement is tied to Medicare. So the impact is triple and quadruple on physicians. So anything that we can do to stabilize that will be important, and anything that we can invest in the movement toward being accountable for the total cost of care and total outcome will be critical as well.
Thank you. Mr. Albanese, in 2015, Medicare program spend was $646 billion, with ACO savings reported at $145 million. $145 million might sound high, but it reflects 0.0002% savings in total Medicare program spending for that year. Similarly, from 2016 to 2018, Medicare program spend totaled $2.128 trillion, with ACO savings reported as $358 million, which reflects 0.0001% savings in total Medicare spending for that time frame. Not minimal, but still much smaller than I think is reflected. Do you think ACOs have been effective at reducing Medicare expenditures? As we evaluate reforms to MACRA, what should Congress consider when reforming ACO models?
So I certainly think that the models that have actually saved some nominal amount of money has been nominal in their savings, as you alluded to. And I think that the concerns that we should be focused on as policymakers and policy analysts is that, first of all, trying to alleviate the incentives towards more consolidation and having bigger providers being able to succeed more successfully in these programs is something that has happened all across MACRA. And ACOs are good in theory in terms of trying to have more accountability for the total cost of care among providers, but when filtered through different government rules and different iterations of the shared savings program, this turns out to not actually play out as was expected and as has happened with other CMMI models and other models besides CMMI.
Thank you, and you led into my next question, Dr. McWilliams. The physician clinical ownership and employee landscape has dramatically changed in the past decade. Private medical practices of all sizes and specialties are being bought and consolidated with larger hospital systems and groups at alarming rates. How do these buyouts and mergers and ACOs and lack of inflationary cost adjustments impact the ability of physicians to participate in new and innovative alternative payment models and stay in practice to give high-quality patient care in their communities versus an independent practice?
Thank you for that question. I think in the theme of today of trying to streamline the portfolio of models and design, have fewer models designed better, I think what we want to move towards is having these APMs make participation worthwhile for independent practices and allow them to remain independent in terms of ownership. Healthcare consolidation is a massive problem. It has a lot of bad consequences for patients, including limiting their options of where they can go. We have evidence that it worsens the quality of healthcare delivery, raises prices, and there's no reason why APMs should not encourage smaller organizations and allow them to thrive. In fact, it should be, payment reform can be pro-competitive if designed correctly.
Excuse me, to that end, there was a 5% incentive payment to encourage providers, and in December of 2022, Congress passed a pared-down one-year 3.5% extension of MACRA's incentive payments. If Congress allows these incentives to expire, what will be the impact on the movement to value-based payment models?
I'm glad you brought that up because this ties into the point about consolidation. The way that bonus is designed, as I said in my opening statement, is as a proportion of revenue. So it favors the bigger organizations. For a primary care group that could participate in an ACO model, it's a very small bump. And so I think we need to have an even playing field in terms of the participation incentives if we care about competition.
And often not passed to physicians themselves. Thank you so much. I yield back.
Generally yields